quietly if they come in a little bit later. Thank you all for coming. I'm Christina Orr. I'm the director of the Golden Area Chamber of Commerce. And if you're not here for the Affordable Care Act seminar, that's okay to say right now. We actually have a live webinar version of this presentation going on right now. That's kind of why we had to go ahead and get your food now, so there's a little bit less background noise. With that in mind, if you can put your phones on silence or vibrate too, just to minimize interruptions. We're also videotaping, thanks to Channel 21 and Tel-All Productions back there, so that if there are colleagues in your office or other people that you know that you think would want to take advantage of watching this, we will have it posted on our website hopefully in the next week or so. So this is a very hot topic, and I know it's hard for people to break away from the office. Thanks for taking the time out to do that. We actually partnered with Pacer Systems to put this on for you today, and with their generosity, they brought in two of their people that are from Kentucky.
Yes.
Thank you. Yeah, right, Cincinnati, Kentucky. We were discussing this last night. It's real close to that area. First, I have Jerry Duffridge and Derek Carnahan. I knew I was going to butcher the names. And they're with NEST, which I'm going to have to cheat and put. And that stands for National Employer Solutions Team. But they are certified Affordable Care Act experts. So, which as that changes all the time, I'm sure you have to read it and things. But the way we're going to do this is he's got a presentation, but we want you to interject with questions as we go along, because there's definitely things, I'm sure you came with questions today. Hopefully some of the things that he's presenting to you will stimulate some more questions. This is a nice sized group to be able to do that with. And I believe that the webinar viewers can type in questions, so we'll be able to look if there's questions from the people that are viewing it remotely, so we'll have that as well. But without further ado, Sherry.
Thank you.
Thank you. And we're going to be co-presenting today, so as Christina said, this is a great size, a nice informal crowd, so we'll be able to hopefully interact and answer as many questions as we possibly can from what we know as of 11:30 a.m. this morning with healthcare reform. Again, myself, Jerry Duffridge, and Derek Carnahan, it was nice for Pacer in the Chamber to ask us to come up and give a presentation. What we're going to do really is give an overview of what's happened since the healthcare reform passed in 2010 on March 23rd. We're going to take a little bit about where we are right now. We're going to discuss some compliance issues with businesses. We're going to talk a little bit about the individual purchase mandate. We're going to have a timeline that we'll address, as well as to some of the things that are coming up immediately. We're going to look at 2001 or January 1 of 2015, and then we'll kind of open it up for a general discussion. There's a lot of questions out there, we understand. If you have something that's on an agenda, make sure you write it down. If you have a question, feel free to get into it as we get through here. First and foremost, we all, I think, have heard of the Patient Protection Act and what is called the ACA now, or Affordable Care Act, Patient Protection Affordable Care Act, passed in March 23rd of 2010. It went into effect. There were immediate items that went into effect in 2010, 2011. There were other items that were placed into effect. A lot of these are going to be on the insurance carrier level that we may, as consumers, have not seen per se in the news, but are taking place in the backgrounds with some of the things that we have to distribute to our customers or our employees. We call it customers. That's a compliance issue. The next piece of this is a photo that we like to use is make sure that you're prepared. And this is the first time that we've mandated, that regulations have mandated that we all must purchase or own a qualified health plan as of January 1 of 2014. So there's a lot of confusion out there. What do I do as a business? How do I present this to my employees? How do I look at planning for my business? How do I prepare an employee benefits package and keep what I have? But also I have employees or friends or myself, even personally as an individual, how do I adhere and start into what's called the exchanges and purchasing healthcare in the future? So the one thing that we can make mention of, and you'll hear this over and over again, is an education. To make sure that we educate ourselves as business owners, but also we take that education down into the employee level and make sure that they understand the different processes and make available to them some different items on being able to purchase and consume healthcare in the future. It is going to change. It has changed. It will change more as we move through this. So it's going to be a different concept that we'll be dealing with. So make sure that we get prepared as a general theme. In the present term, what we're talking about really is what's next. October 1 was a critical compliance date. That was a date that as a business owner you had to have distributed an exchange notice, a health insurance exchange notice, to your employees if you have employees. If you were an employee, you should have received one. That business owner either has a benefits plan or a medical insurance plan that's offered, or you do not offer medical insurance plans. There are two different forms that the Department of Labor put together that were to be distributed. One of which for those that offer medical insurance to the employees, and the second one is if you don't offer. If you don't offer medical insurance to your employees, that form will then be delivered to the employees. The employees can then go to the individual marketplaces or the exchanges and use that to shop for medical insurance, compare plans, and also apply for subsidies because they don't have coverage available at work. I must have a qualified health plan. So we'll go through that on a timeline, and the exchanges is open from October 31st to March 31st of 2014 at this time. There is talk about pushing that individual mandate back. There's talk about extending the March 31st date back into 2014 based on some of the technology problems that they're having inside the exchanges as well. Now the open enrollment, the initial open enrollment started October 1. We're almost through October. I think everybody has heard or read that the exchanges really aren't open for true business. It's not quite clean yet. There's been a lot of activity on both exchanges, both public and private, the federal and the state level. Indiana, Ohio are dealing on the federal level. Kentucky has its own private exchange. Both of them, both the public and the private, are facing their own battles with technology. So I think that's something that we have to make sure that we pay attention to. I know that both sides of them are really working hard to try to get the technology issues straightened out. As far as the exchanges being open on October 1, what that does is it allows an employee to go onto an exchange, whether that's a public exchange or a private exchange. The public exchange is going to be either the federal government at the healthcare.gov, or it's going to be the private exchange through for example, the state of Kentucky, which is Connect, K-Y-N-E-C-T, and it's going to be run by the state. There are a number of private exchanges as well that are going to be owned by private entities that you can opt onto, create an account, and apply for medical insurance. When you opt onto and create an account, you're going to see all the major carriers that you're already used to. Insurance companies are not going to change. It's no different than what you're seeing right now. You'll have your PHPs, you'll have your Aetnas, you'll have the Medical Mutual of Ohio. In Ohio, you'll have United Healthcare, Anthem WellPoints, Humana. All the different carriers are going to be on the exchanges. It's just going to be a general shopping area that people can go and look at different coverages and compare on their own time. So you'll create an account, put your information in, go to the site and be able to compare. At that point, you can choose a plan and then apply for coverage online. I know Anthem on their application and process is once you get to the application process for the exchange, if you agree to that, you have to go off the site. It will take you automatically off the site into the federal government. You key in your information, you put in your income, who's going to be covered, what zip code you live in, and then you bring it back. the federal government will then give you an estimate of what your tax credit or subsidy will be, and then it brings you back onto the Anthem site, and then you can either subtract that from your premium or take a credit at later on your tax return. So there's two ways you can take your subsidy. You can take it immediately, which means your monthly premium reduces, or you can take it annually and extend that over one period for the one tax year. The 6-month enrollment period is again set from October 1 to March 31st. Subsidies and credits are available to those people. If you have anywhere from 100% to 400% of the federal poverty level, you could be eligible for subsidies. From an individual standpoint, if the adjusted gross income is $42,280, I believe, Derek, is the number. So anyone that earns $42,280 on an adjusted gross income and files taxes on a single level will be could be eligible for subsidies. From a married filing jointly, that goes to about $94,000 approximately and under, and so those subsidies will then be able to be factored into the health care and the premium and the cost of that care. Where can people enroll? Obviously the websites. You're going to have healthcare.gov for the federal. You're going to have the private exchanges that are going to be out there. That's one of the situations that we have access to as well. We have a private exchange that has a tri-state area on it, Indiana, Kentucky, and Ohio. You'll have public venues that you can go to, and also the navigators. Navigators are individuals that are going to be hired by the federal government to basically guide, counsel, and assist people into a qualified health plan. Those qualified health plans are going to be commercial and private insurance through an employer, commercial or private insurance. On your individual plan, it's going to be a TRICARE situation if you have someone that's in the military. It's going to be a veterans program. It's going to be Medicaid, Medicare, and CHIP programs as well. So a lot of different areas that people can get covered for health care. The navigators, the difference in primary, the separation as to what a navigator will be versus your current agent or broker is a navigator cannot give you advice. That is part of their contract. They cannot guide you into a specific carrier or recommend any specific plan for you. So really it's just going to be an informational type of situation that you're getting into. Any questions on the initial October 1? Yes?
Did you say initially that the state of Indiana did not opt to do their own state plan, that they opted to take what the federal government has offered?
Yes.
And then you mentioned something about a cooperative in Ohio, Indiana, that there's also...
We have a private exchange that we are, Derek and I, like, for example, yes, and this, you'll see numbers of these. Agents and brokers all over in the community are going to be referencing or utilizing or leasing or aggregating carriers and providing access to that. So we do have access to a private, what's called a private exchange, even though it's a public offering.
And before Indiana residents, even though Indiana did not opt to do a private exchange?
Correct. Correct. And that's a great question, Sue, and how that really plays out is I'll have, for example, I may go on and look at healthcare.gov, which is the federal exchange program. When I look onto healthcare.gov as the federal exchange, I could go on and say I'm looking for a bronze plan. I'll get to that here in just a moment, but I'm going to look for a bronze plan. I may have Anthem Bronze and it may be named something. That same plan may have a different name, but may sit on the outside in a private exchange that would be eligible either through your current agents or brokers or available on the open marketplace.
And would those people going to the private exchanges be eligible for the federal government subsidy?
No. That could be a situation. Yeah. And I say no, there could be some complications in that. And that really also depends is, you know, how, does a person have coverage at work or is available? Did they deny coverage at work because it was more expensive and opt out? So there are a number of different items that the individuals are going to have to pay attention to before they can apply for and secure coverage.
And this is so individualized that it's hard to give somebody a ballpark.
It is.
Answer, okay.
Yes. The general rule of thumb is 9.5% of income. So if you want to think about it this way, and I hope this example will help to clarify what the regulation is trying to do. And for those that, if I can get a show of hands, how many have own businesses that have employees or responsible for this position? If you have that, you may have heard of this 9.5% of income. As a business owner, when you hear minimum value, that minimum value for the employees is I shouldn't have to pay more than 9.5% of my income for medical insurance. When in 2010, March 23rd, when the rule and the regs were passed, it was household income. Now, I also know as a business owner that I'm not allowed to ask that individual when I'm sitting in an interview, can you tell me how much your wife makes? That crosses some lines into HIPAA and privacy. So what they did is they provided a safe harbor opportunity for business owners that allow them only to consider at work for that minimum value 9.5% of W-2 income. However, if I stepped out of that position and went on to the open marketplace and I went to the shop the exchange, the exchange can ask me for what my household income is. So for example, I may be an income of $60,000. My premiums are affordable under my employer, yet when I step to the exchange, $60,000, if my spouse doesn't work and earn an income, I'm now under that $94,000 limit and potentially able to secure a subsidy.
Do you have to change existing policies to qualify for subsidy or assistance? If you're in that entitlement subsidy.
Correct. Are you talking individual or are we on individual? Yeah, that's a great question, because what happens now, and if anybody has an individual health insurance policy, you probably have received a notice saying we can give you an early renewal on December 1st. You can keep your plan through December 1st of next year. Give us all a little bit of time to take care of what's going on and let you just continue on the plan that you have currently. However, next year, you will be mapped, what they call mapping to a new ACA mandated plan. At that point, you'll be changing plans.
So at what point in time would that person be eligible for the tax credit?
At renewal, at your next renewal past January 1. Okay, so if I have an individual medical plan that is effective June 1, let's say I just picked it up on June 1 of 2013, that policy is going to be eligible through June 1 of 2014. At that point, I'll then go to a new reform plan and then be eligible for subsidy. Yes?
Are the prices the same when you go to the public and private exchange? Because you said they're called something, that they're branded differently.
They are. And the pricing should be pretty comparable. From what we've heard, there could be some variances based on what the carriers have told us, but it's going to be pretty comparable. You'll see a little bit of difference. And again, in all fairness, we have access to the exchange, and we were just a couple days ago with Humana leadership. They have their plans approved, they have their rates approved, but they've not been released by the department yet, so we can't load rates, we can't shop. And same way with Anthem. So we're 3 weeks in, and we can't even assist some of the customers in some of the states. But that's, again, once they all get released from the states, then you'll be able to do a full comparison. So you can go to healthcare.gov, look at your premium and subsidy, and then go to the private exchanges as well.
But the prices are based on where you live. So no matter where you go to shop around, whatever site you pick or choose, it's all based on where you live, if you smoke or non-smoker, and how old you are. So again, that's a thing. You don't have to go to the government site. You don't have to go to anyone else's site. Just you can go wherever you go. It's all based on where you live.
One more quick question.
Sure.
Also, can you repeat the questions? The remote viewers are just getting the answers. But additional question as well. Is there a similar subsidy for an employer that chooses to provide private insurance, or are the subsidies completely limited to the exchanges?
Is that from a group standpoint or individual?
From a group standpoint.
From a group standpoint in 2010, and that this it went into effect immediately in 2010, there is a small group tax credit that's available if you're offering medical insurance to your employees. Most CPAs in filing the business taxes are going to pick that up. The way that works, if you have under 50 employees and typically under 25 employees, so if you have under 25 employees and the average income that you have inside your company is under $50,000, then you could be eligible for tax credits. We've seen the maximum tax credits really are when you get under 10 employees and under an average of $25,000 annual income. So there are group opportunities. Do we have more coming through?
No, just that. There were just a couple people.
Okay.
They're just getting the answers, not the questions. They just asked if you could repeat the questions.
Okay, great. Individual purchase mandate, January 1, 2014. First and foremost, one of the things that's coming up is guarantee issue, no pre-existing conditions. As healthcare reform was being put together, one of the things they recognized is it's only going to be effective if we have all participants playing in the game as best possible. We know that that's not feasible, but it helps when the entire group goes in and we contribute in, both as individuals who utilize care and for the young healthy, we'll call it, that they're trying to get into care that may or may not have insurance currently. So guarantee issue and no pre-existing. January 1, Derek and I are in a situation. Derek is extremely healthy. I've had medical conditions. We get to go to the exchange. We're the same age. We live in the same zip code. We have the same family or coverage status. We get the same rate. So this is more of an insurance issue than it is really healthcare reform. It's something I think both of us believe in. You have a lot of genetic issues. You have children who have diseases or conditions, and things happen. Everyone should have access to care. So January 1, that is going to be put in play. So no one will be turned down for medical insurance for medical conditions. All to be covered by a qualified health plan. Again, we touched on those earlier. You have your Medicaid, your Medicare, your CHIP. You have TRICARE, your VA programs, and your private insurance, either through a group or an individual plan. For those individuals that have access but decide not to participate, which will happen, there is a fine also for those individuals. If they decide not to participate and elect coverage in 2014, during their tax filing, they will be subject to a fine. That fine's $95 per adult. It's $47.50 per child, or 1% of income, whichever is greater. 2015, that steps up a little bit. You'll see that it goes to $325 per adult, $162.50 for children per child, or 2% of income. 2016, it goes to $695 per adult, or $347.50 for our per child, or 2.5% of income. So that's the incentive to get people enrolled. The decision that you're going to find and you may hear or may see is $95 a year if I'm a single. It's $8 a month for not having coverage. What risk do I want to take? That's the challenge that the government is going to be faced with in progressing the programs forward to keep it to keep this program moving. So, any questions on the individual underwriting, the pre-X taxes?
You know what the max is, I'm like, for 2014, you have a max of fine.
For 2014?
280.
Yeah, it's going to be per family member. So if I have 2 adults and 2 children, I'm going to have 95 times 2 and $47.50 for my 2 children, or 1% of my income, whichever is greater. Yeah.
Isn't there like the max though, maximum of,
It's 1%. Yeah. So if we're a family and our adjusted gross income is $100,000, I don't qualify for subsidy, I elect not to have coverage, I'd pay a $1,000 fine. And that's going to be subject on your next tax filing for 2014, filed in 2015. So a lot of the refunds may be reduced. That's where they'll adjust it. Yes.
So what happens if there's a married couple, and the children, but one's over 65 and one's under 65?
Great question. You'll have one responsibility to pick up coverage until that person then bridges into Medicare. Medicare is obviously, once we get to 65, different animal.
You just used the analogy of you two, same age, same everything for the most part, same zip code. One of you have poor health, one has good health.
One has hair.
If you were, let's say you were a cancer patient and $30,000, $40,000, $100,000 worth of medical claims last year, you're saying that your cost is going to be the same.
Exactly the same.
And if I didn't
It's
have
hard to
insurance,
visualize.
January 1, I am covered, all pre-existing, everything's covered from January on.
Yep. From January 1, I would be covered for that cancer, heart attack, strokes, diabetes. Diabetes is, and 2 big primary issues going on right now are diabetes and you get into the Alzheimer's scenario, the early onset of Alzheimer's. Even juvenile diabetes, the kids with cancer, that we're going to have access to that immediately. Maternity will be treated the same way. So that's the way that it would work. They did limit through March 31st. Initially, the way the regs were written and were going to be implemented was potentially that I could get in and out of the plan at any point in time. So if I wanted to pick up insurance, I could buy insurance. When I didn't need it, I'd drop it. So that's why they put they're following a lot of what Medicare does right now to answer your question on the Medicare of an open enrollment, the annual open enrollment period. So instead of me going out and playing softball, having no coverage, saying I'm going to pay a $95 fine, and I slide into second base, I blow my knee out Monday morning, I get coverage, then I go to the orthopedic surgeon, I get my knee fixed, and I drop it. They didn't want that in and out. So once you opt in and you get into the plan, then there are certain, there are mandates. If I got out, I can't get back in. Yes.
Do you see any advantages, excuse me, of an employee who, let's say, meets that 9.5 test with their employer as having affordable care, but that's only on that individual's income? But then let's say, if they look at the exchanges, and the exchange is taken into play total household income and dependents, and let's say that dependent, or that employee would have a spouse that doesn't work and 4 kids. Would you see any advantage of an employee in that situation going to the exchanges and getting a greater amount subsidized versus what he is paying for benefits through an employer?
If they have if the employer coverage, and those are the notices that went out October 1, that everybody had done the test on their plan, whether it's affordable or not. And if you have an affordable plan at work and you're meeting that where it's less than 9.5%, so it's a minimum value, and affordable, and making contribution typically into at least a single rate, if not family coverage, then that person goes to the exchange, they're not going to be eligible for subsidy.
They are not.
They will not.
Okay. As long as their employer met the test.
Correct. Yep, as long as they're meeting the tests and it's offered. So you're seeing a lot of plan design changes and a lot of changes in how compensation is going to be delivered, or structure contribution strategies, whether we're going to pay for just single and dependents or we're going to pay for the employee and children and family, or maybe, like the spouse. A lot of companies are eliminating spousal if the spouse has coverage available at work. That's been going on for quite a while. But you'll see more of that as we go through. Any questions on this? From a group standpoint, if you have a business, there are 3 primary items. One we just discussed as far as the exchange notice that went out. The second one is as of January 1, the waiting period on your group can be no longer than 90 days. In the past, there are those were defined by state level, so you could have first a month following 90 days. That is now the federal rule trumps, and that will be now limited to just 90 days. And then the second is if you have anyone has a business over 200 employees, there's going to be an auto enrollment feature where you have to enroll people on the plan effective January 1 of 2014. Do we have anybody over 200? Good. Good. Well, not to say that we like to limit your growth in your business. We hope you all get there. But if you do, make sure you understand auto enrollment. The bronze metallic plans, if you haven't heard this yet, you're going to hear a lot about the metallic plans. You're going to hear bronze, silver, gold, and platinum. These are the different types of plans that are going to be available to the individuals on the exchange, and also you'll see it on the group side. And what that is that's an actuarial value of what level of coverage is going to be paid. For example, the bronze level plan is going to be a 60% coverage. Silver is going to be 70, gold will be 80, and platinum will be 90. What that means, if I have a $10,000 claim, from an actuarial standpoint, a bronze plan will cover $6,000 of my $10,000 bill approximately. Gets into pretty deep calculations, but really the way that it can't be exact at 60, so a bronze level plan will probably be between 58 and 62% is what the standard says. A silver somewhere between 68 and 72, and so on up the line. Now, those are going to vary obviously quite a bit, and it's going to be the standard now. So you'll see 4 different types of plans. Medicare, when Medicare changed a number of years ago, they went to some standardized type plans so it would make it more understandable. You'll see all the metallic plans moving forward as we get through this. All right, open enrollment closes March 31st, 2014, right now. If technology continues, I wouldn't be surprised if we didn't see either March 31st extended through 2014, or at least to October 1st, 2014, to give that opportunity for the technology to open up, or there's also talk of filing back in for more legislation where they move the entire mandate back. That's really going to depend on how much activity gets put inside the exchanges and how available people can get in to enroll. So we're kind of a waiting game right now, and hopefully they continue to make progress as we get through this. Special enrollment periods. I'll hit this for just a second. A lot of the times the question comes up, what happens if I enroll in coverage or I have coverage right now and my business owner decides to drop coverage during the year and leaves me without, and I'm past March 31st. There are going to be special enrollment provisions that are going to allow an individual to get to the exchange. So those are, they're out there. Again, it's something we could probably spend another 2 hours on going through special enrollments, but they're out there, and it's going to be a situation where you can get onto the exchange. The next is the employer shared responsibility. Again, as far as an extended discussion goes, this was the employer shared responsibility that was supposed to be intact on January 1, 2014. Because of some of the items going on, the confusion, the frustrations with business owners as to what is my responsibility to offer medical insurance benefits to my employees, they pushed that back to January 1 of 2015. It's good thing, bad thing. It's just one of the things that's happened, but it does give now business owners a little bit more time and effort so they can look at their business and make informed decisions and put plans in place to be able to figure out whether they want to offer coverage, and we'll get into it in just a moment, or pay fines and offer maybe some additional monies to the employees in lieu of medical insurance benefits. In a basic term, what we're going to do is we're going to talk real quickly about this. Full-time equivalents. Full-time equivalent is going to be an employee for full-time status now is going to be determined at 30 hours a week. So if I work 32 hours a week, I am considered full-time. If I work 28 hours, I'm part-time. However, as a business owner, what you have to do is you have to take into consideration your full-time equivalents. So I take my full-time employees and I put them in a bucket beside and I count them. So if I have 70 employees, let's say I have 30 full-time, I take 30 full-time employees and I put them aside. The other 40 employees, I total their hours, I divide it by 120, and I get what's considered my full-time equivalents. So I could have these employees working 10 hours a week. My full-time equivalents would then add to the number of full-time employees I have, and that would then approach the 50 employees, that 50 full-time equivalents. So if I have 30 full-time employees, I take all my full-time equivalents, my part-timers, I add all those part-time hours up, I divide by 120. If I'm at 47, I'm not obligated to offer medical insurance and I don't have a tax on my shoulders. Okay? If I have 45 full-time employees and I have 30 part-timers and I end up having 58 full-time equivalents, I'm now going to be responsible for the Employer Shared Responsibility Act that triggers the tax. I now may have a tax due on those employees that on my full-time employees. So this is a little more complicated, and this is one of the reasons that the government pushed this back, is it's complicated to figure out this this calculation. One thing I can say as a compliment to Brent and some of the payroll companies out there, they have generated reports for your business owners to be able to calculate what's my full-time equivalents for each month, because as of January 1, I'm going to have to start reporting into the government how many employees I have so that I can keep my full-time equivalents so they can track where my responsibility is for the tax. January 1, 2015, as we get through this, we'll have a $2,500 $2,000 fine or $166.67 per month on all full-time employees. That's full-time only. So if I have, again, take that scenario, the government is going to give me an allowance of 30 full-time employees that I don't have to pay a $2,000 fine on. So if I have 45 employees, full-time employees, I take 30 off, I'll have 15 taxable or finable employees times 2,000, I owe $30,000 in tax that year. So that's the Employer Shared Responsibility Act that was moved back. If you haven't calculated this, you haven't looked at it, and you have near that 50, or you have a lot of part-time employees that may trigger that, it's time to, that's the 14 months we have now to start paying attention and looking at that plan for the future. The business owner is going to report monthly and pay annually. Now, mathematically, we have January 1, 2014, an individual mandate. I go on to the exchange, I pick up medical insurance, I get a subsidy. January 1, 2014 was also supposed to be the date that the business owners were to report and then pay a tax. So I report monthly and I pay annually. I file my taxes in March. So I'm timely, or October, either way. So that $2,000 is the portion of the tax and the revenue that's going to be paying for the subsidies that are outgoing. So I'm immediately creating a line of credit of 15 months minimum for the subsidies that have already been paid out for January 1 for the individuals that are now purchasing. That got moved back 12 months. So we're 27 to 33, 34 months now from collecting from those business owners those $2,000 fines to pay for the subsidies that we've now offered to the individuals on the exchanges. That's the math question that hasn't been asked yet. So that's what's going to be interesting to see how this plays out.
I got a question. On that fine,
Yes.
that would only kick in if you didn't offer insurance, correct? It isn't across the board.
If I do not offer medical insurance, then I'm going to have a $2,000 fine. Correct. If I do offer medical insurance and someone does step out of my plan and does purchase medical insurance and gets a subsidy somehow, I get a $3,000 fine on that individual. Again, we're kind of sketching through this, but these are 14 months now. If you have 50 employees or 50 full-time equivalents, these are the things you need to be thinking about and planning.
But I thought you said that if an employer offered insurance, an employee would not be eligible for subsidies under the market.
Correct. And the question was if an employee went out and was offered health insurance, wouldn't be eligible for the subsidy, but again, it's just a question on an application. So what if that employee checked, no, I am not offered health insurance through work, and did end up putting on his wife and children, qualified for a subsidy, later on, that person gets audited, you get a letter, and all of a sudden you owe that $3,000 fine, and that'll probably be more than a few months later. So, and what happens if employee Jimmy also is in a department with 5 other guys, and he comes back in and goes, guys, you can't believe what I just did. This is great, man. And all of a sudden, Fred, Greg, Sue, everybody goes out and does it. And then all of a sudden, that employer is getting hit with a $3,000 penalty for 10 people. And that's where, again, all this reporting and taking a look at all of this.
The other thing that could happen during the year, we may go in January 1 and test for affordability. Everybody falls under the 9.5% limit. Person gets a raise, or that medical insurance premium goes up, or the company cuts their contribution strategy, and I go to 9.8%. Now it's not affordable. I can go get subsidy. So, a lot of factors, a lot of variables in there. Brings us to next topic. If there's nothing else that you take away from today's meeting, there are two primary items that we like to discuss. First and foremost is education communication is critical and key. As nervous and confused and anxious as we are, so are our employees. So are the people we work around. So are the people we talk to. This is very confusing. It's a big, big change for our entire culture, our entire economy. So if you have a business, we really recommend figuring out what you're looking to do, what you're currently doing, what you're planning to do, and have some sort of a communication strategy back into the employees that you have. We feel it's mandatory and responsibility as business owners. The second piece of that is right here is assemble your team. Everyone has a team right now. We may have 12 different teams. We have 12 different advisors. These advisors should be working, communicating, talking, and become more and more involved in your business and working together on the outside for your best interest as business owners. And as we go through this, it's going to take a lot of different people. First of all, your financial, you may have a financial advisor or guidance individual that you're look to. Healthcare is included in your personal plan. Everyone now has to purchase healthcare. Make sure you understand what it is and how it works. We've all probably purchased vehicles. We spend more time purchasing a vehicle and the insurance for it and changing the oil and doing wellness on our vehicle to make sure that it lasts longer than we do ourselves, and we do our health care. You wouldn't go to a health insurance plan and purchase it on a mouse click, not knowing deductibles, networks, co-insurance, co-payments. You sure wouldn't buy a car that way, and you wouldn't take a vacation that way. Most times, I should say. So again, from a financial standpoint, make sure you talk to your financial advisor. If they're not bringing healthcare into the talk, make sure you bring it into the discussion. It's critical. If anybody has health savings accounts, most health savings accounts either have a zero balance and I maintain, I put in and I use it as I go, or I have a large balance in there. How do I protect the large balance from a catastrophic claim, or how do I protect that zero balance in the event that I have to pay a bronze level deductible at $4,000 and then co-insurance? So a lot of different pieces that are going through here. So there's wealth protection and also making sure that I don't have a devastating event from a financial standpoint. Your insurance agents or brokers, make sure they're involved. This has kind of landed in the lap of our industry as a quarterback to this whole piece. Some enjoy it, some don't, some have embraced it. We've kind of embraced the fact because we think it's critical. We can't change it. That's the difference between politics and policy. We now have to purchase. So let's embrace it and do what we have and go about it the best way we can. But let's also make sure that we're educating ourselves with the other people. So you're going to have where's the risk management? We have premium versus utilization. We have support and claims and service. Good news, bad news. I go on the Federal Exchange, I click the button, I get a health insurance plan. They send me a card. I have a major claim. Who do I call? Federal government? The exchange? They're not going to answer those questions. You'll be dealing with the carrier, which is fine, but we're going to have a lot more activity going into the carrier level too. If you have a current agent or broker, continue to use them and utilize them in a lot of different ways, and ask them, how are you going to help and assist with any claims in the future? Legal counsel. Important, especially for those that have employees that may have contracts, adjunct faculty, 1099s, contract employers. Make sure if you have a contract employer or employee, if that person is doing contract work for you, that you're not the only employer they're working for. because that can be considered then an employee of your organization. And is that going to affect anything that you have with your benefits and moving forward? Compliance, make sure you stay in touch with any compliance and also the structure of your business. Accounting, obviously. If you have an accountant, start now. I have a business that's close to 50 employees. I'm looking to buy, I'm looking to merge or have an acquisition. How do we get through and plan for this for next year? What's the difference between me just dropping my medical insurance at over 50 employees and paying a fine versus offering benefits? Benefits are going to be a tax deductible event from a tax standpoint. The fine is not. So the net cost, you have to make sure you're weighing in the net cost. Second piece, and I give Brendan here a little plug, first time we've ever really had to have a situation where we may go to our payroll companies and say, I need a report generated. Is there any way that you can generate this report because my accountant, my insurance broker, and my other advisors need this? So working as a team is going to be critical in the future, and we feel that it's absolutely mandatory for business owners' responsibility to educate themselves, the employees, and also to make sure your advisors are speaking and working with each other. The business owner's decision, here's what you're going to have. You're going to have 3 different levels: pay, play, or redeploy. And that's the decision maker, the decision that each business will make as they move forward. First of all, you can play in the game. I can continue to offer medical insurance. I have to attract and retain employees. That doesn't go away. We own businesses. We're looking to grow and expand business, maintain business. We have to do it with our key asset, which is our people. How do we attract people? How do we keep them? If it gets too expensive or cost ineffective, we call it, then what are the options I have? So I can continue offering, look at different plan designs. For those that are stepping into a larger company, and a lot of this is fully insured medical insurance, you'll see a lot of self-insured programs coming about. Self-insurance will start stepping down from typically 7,500 employees down into the 35 to 50 range, just so they can get away from some of the mandates. Supplemental benefits and services. This is going to be the new segment that you'll see a lot of. You're hearing a lot of it already. If you haven't, you're going to see more and more of it. If I have a bronze level plan, I'm offering it to my employees, how do I get $6,000 to cover a heart attack, a stroke, a cancer, an accident, a catastrophic event? So those are going to be the big issues in filling gaps in those items. Compliance administration, making sure that you stay on top of your compliance as a business owner. If, again, we have that 27 to 33, 34 month period where the government is now giving this line of credit for the subsidies, they may be making this up in audits. They may come and have the 90-day waiting period. If you if an employee late enrolls into a medical insurance plan, it's $100 per person per day that's not enrolled timely into a medical insurance plan. So you got to make sure your administration's in check and your compliance items as well. Next, I can drop my medical insurance plan. Say this, I've been waiting 10 years to get out of the medical insurance business. I'm just going to pay the fine. Again, that magic number is full-time equivalents at 50. The full-time equivalent triggers a penalty. We've kind of talked about those. The next is redeploy my assets. If I was offering X amount of dollars to my employees for medical insurance and I dropped the medical insurance, how do I get that money back to the employees? How do I counsel them on then going out to purchase and be responsible for securing coverage? That's going to be the items. Restructuring hours, restricting hiring. Really don't want to do that, but some businesses are going to look that direction. And then reviewing employee status and contracts. Our approach that we're going through this, Derek and I kind of looked at it a couple years ago, and we came up with an acronym. We call it the EASY approach. It's not necessarily easy, but it helps us remember what we're talking about, for one. But it tried to simplify a couple different items. First of all is educate. Educate yourself. Educate your employees and your staff. The new benefit may be not necessarily a medical insurance plan, but the communication package that goes around with it and the counsel that's being provided into your employees. Do I offer or not offer medical insurance, and redefining what my benefits are going to be. Assessing where you are, assess where you want to be, your goals. How do I attract and retain employees? That's still going to be critical. Making sure those goals are in place, and then I strategize. We still have to do this within a budget. So how do I put the strategies together, plan designs? What's my opportunity cost of losing an employee versus the benefits that I may be taking away? Crafting a plan, integrating the plan with different supplements and services. And I say services for the sole reason you'll see a lot more on the edge of claim services, concierge services for healthcare, for resolving claims and finding care. Supplements, again, we touched on that one. That's going to be a big item in the future. And then implementing the plans, that's, if I can get to one more point, communications. Communicate, communicate, communicate. It's going to be critical for the employees and the staff. Up here on the top left side, changes. It's a process, not an event. We've seen changes since 2010. We've seen changes in the last 10 days. We've seen changes, we'll see changes in the next 10 hours, 10 days. It's just going to change. It's something we're going to have to live with until it does shake out. Understanding it, creating your team, communicating, ask questions, utilize the resources that are around you. That's critical. At that point, I think we can open it up, and I should probably read some questions from here. In the meantime, Derek, I'll go ahead. We have any questions, we'll go ahead and get started, and I'll see what I can.
This is more of an opinion question, and maybe it's a loaded question, I don't know, but it appears to me that if you take a company that has 100 employees and they opt out for insurance and decide they're not going to offer it, the first 30 are free. So if you have 70 left, that's $140,000.
$140,000.
What direction do you think these employers are going to take is the question, because it's a $140,000 fee. I get it's not tax deductible, but it's a tenth of what the true cost of medical insurance is, approximately. So in the overall scheme of things, they're saving themselves $800,000, $900,000, just $1 million, and that's just with 100 employees. So it appears to me that we're trying to push this in a direction that businesses don't offer health insurance anymore, or at least it appears that way from the surface. Do you comment on that?
Oh, yeah. Oh, yeah, plus.
And maybe everybody knows that, and I'm just figuring it out.
No. Go ahead.
You're exactly right. The question was, if I'm sitting there with a 100-person group and I decide and I look at the penalty versus what I actually am spending on healthcare, which way am I going to go? And that is, right now, this is a benefit that we all rely on for where we work. And it is getting shifted to more individualized. Again, back on some of those things where we said redeploy, someone's going to look at that and look at the penalty, look at their full-time or full-time equivalent employees. If I'm sitting there with 100, well, maybe 20 of those 100 are part-time, or maybe they're at 32, 33 hours a week. And all of a sudden I say, Sam, you're great, but I only need you 28, 29 hours a week now. And so, I figure out my penalty, and all of a sudden, yes, I'm paying that $2,000 penalty for every full-time employee over 30. Well, that only might be 60 people. And so, yeah, that's where this is all going to go, and you're working with your team, your advisors, to figure out the best strategy.
Yeah, and let's take your $140,000 exposure to the fine. Let's say the premiums for those employees that you were coming out of pocket was $200,000. You have to take that net cost. We take that off a deduction. We run that through. Your accountant would run a study and say, well, you're at this tax rate, and you know what? If you pay your benefits, it's going to be $145. If you pay the fine, it's $140. Then we get in the opportunity cost of what happens if I have those 2 sales folks leave because I took benefits away. That could cost me $50,000, $80,000, $100,000 just in replacing those 2 employees. You know what? Maybe I'll just keep the benefits in place. If you're talking about an expense where it's an upwards of $600,000, $700,000, I'm not much of a math guy, but that's just the decision. You'll also find the business owners that, one, have a great culture, care about their employees, and want to continue doing what they're doing for the care and concern of the families. And you'll have some that say, hey, it's, you know, I'll find someone else to replace you. And it'll be a case-by-case study. We've seen both. There's a question, Jason, because of the chaotic nature of the Affordable Care Act as it stands now, would you recommend small and medium-sized businesses to keep their company insurance until things become stable, or force employees to look at the public exchanges now? I think that steps right back into the scenario we just spoke of. If you're under 50 employees, we don't have to offer medical insurance to our staff. However, if it helps us attract and retain employees, then maybe that's something that we continue. If we do, or if we don't offer coverage, then what's the responsibility? I can either turn my employees loose, hope they go out and pick up coverage. They mouse click on an Anthem plan that has a skinny network that the people don't understand searching for networks or providers. The providers are no longer, it's not the same Anthem network as it was 3 weeks ago, because we've changed to an ACA platform and plan. So the network's changed. That's the unfortunate part of when I carry an insurance card, I think United Healthcare is United Healthcare. It's not going to be that way anymore. So.
You mentioned cost, and I'm not an HR person, but it appears to me that the analogy that we just used with 100 employees, if we first 30 or 3, 70, it's going to cost you 140. I'm guessing, but I would guess that the benefits for those employees would be well in the $600,000 to $700,000 range. So that's a massive, massive difference.
It's a big difference, absolutely.
Any questions?
The question is, how is this going to affect labor unions, teachers unions, all of those things? Because those are big, massive entities that are.
They are.
Yeah. The business owners that have a union or collective bargaining agreements are going to be treated separately, because the employees are still going to be under the collective bargaining agreement, so you may have to carve those out. Again, in those situations, what you need to do is you need to make sure that if you have a collective bargaining agreement or a union involved, you have to make sure that your advisors, your insurance broker, consultant, agent is aware of that and how those regs are going to play. Probably pull in legal counsel too, because there are 2 people that don't want the obligation, one of which is the union, because they don't want that contract or your responsibility, and you don't want the entire union's responsibility placed back on you. So again, it's just, that's going to be an educational point that you have to look at, and you have to look at the contract and how the union is written with the agreement that you have. But it's a great question. A lot of this is just going to be case by case. Yes?
Looking down the road, and we kind of got in a conversation yesterday about this, is, they're assuming, when you're coming up with the rates, that you're having a lot of these young, healthy males opting into the system. And of course, penalties for them are probably at $95, a lot cheaper. in the long run, I mean, is this whole thing implode because businesses are opting out, individuals that are gonna create that balance in the expenses, costs or whatever. I mean, what do you, are the experts saying down the road that this thing could actually fail, or?
Right, now you've crossed the line between expert and ESP. It's a great question, and I don't disagree. We just don't know who's out there enrolling, and we don't know how this medical insurance pool is being built. And really, that's what it is. You know, the basic of the whole process still is a dollar's worth of health care still costs $1. So if I go to the doctor and he charges me $100 for a visit, it's not like this is free and they're magically grabbing $10. It's costing $100, either in private insurance or co-insurance or deductible or co-payment. Someone is paying for that amount of money. If an individual does not opt into the plan, and it will happen, then they'll still be responsible for those claims. So if I'm a 22-year-old male and I opt out, I pay my $95 fine, and I go to a specialist and I have a torn ACL playing softball on a Saturday night, that responsibility is now mine at 100%. Insurance is just the transfer of risk to an insurance company and spreading amongst the pool. That goes all the way back to ships in England when they sat and, you know, Fred sent 6 out and Derek sent 2 out, and we hope they all come back. If not, I'll help Derek and Derek will help me. That's where insurance started. It's just a transfer of risk. People don't understand the transfer of risk. When that knee surgery comes and I get a $22,000 bill, I owe the money. If I can't pay the money, now I'm back to financial responsibility of me versus the hospital, the doctor, and the different providers. So who's going to be responsible enough to take that versus making the financial decision of saying 95 is cheaper than this one? I wish we knew that.
That is the adverse selection that all these carriers are trying to figure out, knowing that, you know, right now the people, it's not easy. You know, the sites keep crashing, all the carriers aren't out yet. They're going to sign up. Are the healthy people going to try that hard to get signed up?
Yeah, it seems like it's gonna be the people that are unhealthy, that haven't been able to get insurance, that need the subsidies, are gonna flood the marketplace first. And, you know, are the rates they're putting out there based on, you know, your usual actuarial figures or pool of people who are low income and unhealthy?
Yeah, has anybody seen they're starting out with some new commercials and advertising? You're going to have a lot of professional athletes and celebrity types. It's if you haven't seen it, it's on its way. They're going to be promoting people to go to the government sites and to the exchanges and to get covered, and so they're going to be leaning on a lot of folks. There's a big, I mean, this first year really is critical. 6 months is critical. And we're set behind really a month because of technology issues right now. Christine, I wish we knew that. I'm like you. I have a feeling as to where it would go, but
She makes a really good point. If 60 or 70% of all businesses opt out, and it gets to the point where people can't afford it. I mean, if it fails after 60 or 70% of businesses opt out of insuring people, then you've got a real problem. We think we have one now.
yeah. And again, I think as we move through, again, trying to separate politics and policy. Policy's in place right now. Politics aside, if that happens and we don't have the activity into the pool to generate and to bring those healthy individuals into the pool, to bring utilization down, and adverse selection happens where we have all, you know, the cancer, strokes, diabetes, any chronic conditions, whatever, that are utilizing the care and now know they can get it, then prices are going to go up. As it gets more expensive, you'll have more people on the bottom end of the scale to look at it and say, well, I want to get out now. I can't afford that number anymore. My subsidies changed.
And then when they do have an accident, they can't afford the medical insurance, which in turn creates more bankruptcy and more unpaid medical claims, and which in turn increases premiums.
Is anybody familiar with the old association plans? I mean, I probably one of the more senior folks in the room, but when you go back to the old association plans, where I used to say, you know what, we've got really good rates. We've got 500 businesses in our association, and we're going to put them all together, and we're going to create this nice medical insurance plan. We'll have all of our association members can have these nice rates, and that was good until all of a sudden the young and healthy figured that they could go get it cheaper somewhere else, or just opt out of it altogether, and then the people that remained in the association plans were those that couldn't get it elsewhere or knew they had to get it. Adverse selection. So that's the challenge. That's why you're going to see the big promotions. That's why you're going to see the big push. That's why you're seeing billboards, TV ads, newspaper ads. USA Today. I saw it last week. It was a full-page ad across the banner. Healthcare.gov. Saw one in Kentucky, same way. Sunday newspaper, open it up. All across the bottom. Connect.com. That's the private in the state of Kentucky. So there's promotions going on everywhere. Libraries, I know that there's a lot of activity going on in the public libraries in the larger cities. It's just it's critical time. So.
Don't want to dominate it. Looking at the Kentucky Town, it plans the bronze, silver, gold, and platinum. I tried to get on and look. I couldn't see anything about what's co-pays and deductibles. You know, these plans, good plans, are they barely covering? Do you know what I mean? Are we talking $10,000 deductibles? Or are we talking, you know, I know there's some amount of choice, but I couldn't even get on to tell what they don't really look like.
Right. There are plans that are out there that you can see, and it's something that we can email you. That, you know, like for example, one of the scenarios we looked at the PHP plan, the individuals. So we have those plans and what they look like.
But you've seen, there's decent plans. It's not like they're all super high deductibles and.
We've seen deductibles, initially written in regulations, deductibles weren't supposed to be greater than $2,000 single, $4,000 for family. And Sue, you notice that. What happened was when the insurance carriers went to the departments of insurance and said, we can't fit 60% in a bronze level plan. We don't have that, not with $2,000. They're also, the maximum out of pocket limit is going to be your HSA limits of the $12,300 or whatever it is. We can't put 60% in that box. We can't make bronze out of that. Plus, we already have about 50% or more of our block of current pool that has a larger than $2,000 deductible. So they allowed that, they granted an allowance to have those deductibles range. Now, when you do that, you move a $4,000 deductible, you're going to have an out-of-pocket that goes down. You know, you'll see your out-of-pockets move around. You'll see your co-insurance percentages move around. You'll see what was a prescription card may no longer be the prescription card that someone's used to. It may be your generic drugs are going to be covered. Everything else is going to go toward your deductible. So if I'm on a brand name drug, instead of getting a $10, a $30, a $50, and a $75 level drug card, I may get the generic card and a generic MAD for $20. Yet if it's a brand name, it's going to go to my deductible at $4,000. So I'll pay 100% of all my RX up to that level.
And those things aren't regulated by the PPACA.
Right.
However, could you clarify, the insurance plans on the exchanges, are they in fact under the same restrictions that private insurance employers have on their plans?
Yes.
Okay. Okay.
Yeah. you'll see some variance in plan design, but yes. Yeah, because it's all going to be based off, I'm sorry. Yeah. It's based off the actuarial value, that's 60% for bronze.
But you will see network differences as well. You know, so the plans might follow the same guidelines, but then you're going to have ones that have different network than
And
the
like you
others.
said, skinny
Correct.
networks. And that's not regulated by those kind of plans are not regulated. I was just wondering about the maximum out-of-pocket limits.
That's-
and the
that's-
deductibles, the copays that now have to go toward out-of-pocket maxes.
You'll see both. Yeah, you'll see both. But the maximum allowable out-of-pocket is going to fall on the HSA guidelines, the health savings account guidelines. So now when you talk about skinny networks, this is getting back into the financial. I talk about a skinny network. I have a $4,000 out-of-pocket. I buy I mouse click my bronze plan because I can afford that premium. I have $4,000 out of deductible and $8,000 out of pocket. I don't do research on my network. I take my child into Children's Hospital. For the perfect example is Cincinnati has a great Children's Hospital, one of the top 3 in the country. I take my child into Children's Hospital because I'm concerned and want to get care. Children's Hospital is not going to be on one of the carrier's networks. So my deductible then doubles, my out of pocket doubles, and I can now be responsible for an $8,000 deductible and potentially $16,000 out of pocket for taking my child to Children's. So these are the things that we have to be, making sure that as business owners, we're responsible to the employees and their families to communicate this back. How do you do it? It's going to be a challenge for all of us. We've been working for the last 18 months. We're going on site. We had one scenario. We have a group that makes down pillows and comforters. We have a group of Spanish speaking. We have English and we have Vietnamese. So we hired 2 translators. And we gave basically this talk that the business owner may be making changes in the future in 3 languages. But those are the things you have to think about. Questions? Yes.
If an employer has a high deductible health plan and they put a large amount into a health savings account for the employee, would that be taken into consideration when figuring if the plan is affordable for an employee as a percentage of their income?
That's a good question. The affordability is going to be based off the insurance plan.
So only the insurance premium itself?
Yes.
Okay. No matter how much would go into their HSA?
And getting back into a scenario that a question came up last night that Sue had posed, in 4 years that could play into a test for the Cadillac plans. So you can't discriminate.
But typically, HSA plans will have a lot lower premium amount, and currently, they're only gauging that on premium costs,
Premium costs.
not what an employer might put into an HSA.
Correct.
So my guess would be that would definitely meet the test of affordability.
Correct. Does that answer? Because it's going to be on the insurance plan design. Any other questions?
Going back just a little bit, you mentioned the contract workers, and if they are only contracted through one company, then they will be considered an employee of that company, then, right? Is that what you?
Not will. Yeah, and that really falls back to a legal case in the 90s from Microsoft. Whereas Microsoft, when they were growing, in the 90s, they hired a lot of contractors and put them in cubicles to build software for them. And they wouldn't hire them on as employees because they didn't want to pay for the benefits, they didn't want to pay for the pension, they didn't want to pay their taxes or anything else. So they hire all these contractors. So you have, a bank of 100 or whatever LLCs that are out here working for you. It's the only place that they worked. So the government came back and the Supreme Court came back and found that since those employees never left their seat and only worked for Microsoft, that Microsoft owed them benefits and the FICA taxes and everything else. Big, big case.
And you can find the answers to whether or not you need to put an employee through a test to see if they're an employer or a subcontractor through Fair Labor Standards Act.
Right, the FLSA.
Yeah.
Yeah. And that's a great point, Sue, because that it's, again, let's if forming your team of advisors, call your attorney and make sure you can do that, or change a contract.
Or don't pay your attorney.
Or go to Sue.
There's an easy test that you can find out if you go to Department of Labor under Fair Labor Standards Act, and you can put those employee job descriptions through that test. Typically, one of the strongest points in the test is that if you dictate their hours, of work, they're going to flunk the test and they're an employee. Okay, there's other factors, but that would be a really good test.
That's a fantastic resource.
The Department of Labor wants to help, and so I would, if you have that close, I would reference that.
Well, if you want, you might call them 1099 employees, but if they don't meet the test to be a 1099 employee, then you could be subject to fines because they are considered under Fair Labor Standards Act as an employee. Then you got a whole other mess.
Before we get finished, because we're real close to the 1:30 time, great resource. If you haven't been or haven't seen and you're interested in learning more, Kaiser Family Foundation, KFF.org, KFF.org is a fantastic resource. They have a great decision tree and a model out there. We use it over and over again on how to purchase individual insurance and what the responsibilities are. Also on the pay or play for the business owners. There's another model out there, a decision tree that walks you through the decisions. That's fantastic. Interestingly enough, a lot of the sites now that are estimating the subsidies are taking you out of their site and are referring you to Kaiser. So Kaiser, you can go and calculate an estimated subsidy based on where you live, then bring that back in and use that as an estimate. So great site, kff.org if you don't have any. Healthcare.gov is a good resource as well. And again, Sue, on the Department of Labor, that's a great call if you have a local or can get access to that. Any questions? Again, thank you guys so much for coming. Thanks for having us. Hospitality has been wonderful. Brent, Christina, both of you, thank you very much.
Thank you guys both. I know I learned a ton today, and hopefully it helped everybody in this room too. Are you guys going to stick around a little bit afterwards?
We will,
too?
yeah. We'll
Okay.
stick around for a while if anybody has questions.
Things like that. But thank you all for coming. Again, hopefully in the next week or so we'll have this up on our website. If for some reason we don't, technical difficulties, email me that you want a copy of this presentation to maybe share with, like I said, your colleagues, and we'll make sure you get it. Thank you all for coming.
Thank you.